Welcome to this edition of Take 5, where we present EMS topics and tidbits aimed at helping you to maintain or improve your practice. In this presentation, we will explore the differences between suspected or confirmed cardiac dysrhythmia patients who are stable or unstable. It is sometimes confusing, especially for newer providers who perhaps haven't seen a wide variety of presentations. So let's dive in and examine this topic. Before we get too far into the reasoning part of this presentation, let's make a quick assumption in order to keep this down to a 5-minute clip. The assumption here is that we are dealing with a patient who has been at least initially assessed, and through those findings it has been discovered that they have a pulse that seems too fast, too slow, or is irregular. If a monitor has confirmed that they have a dysrhythmia, then that will work as well. Now, one thing I have always preached to my students is that not only do I not want them to be cookbook medics, but rather that I simply will not tolerate it. As practitioners, we must become adept at doing patient assessments and learning to actually read our patients. Doing a simple check of a pulse can tell us nearly as much as a monitor, and actually looking at the patient's condition and interacting with them will tell us things that the monitor will never be able to. That is why I earlier said that if you already have a rhythm, that will work, but I actually prefer it early in the interaction if the rhythm is an unknown, because it forces you to become a clinician. So with that being said, which of the following do you need to make a determination of stable or unstable? I would venture to guess that a good many listeners are having a hard time keeping their eyes off of the ventricular tachycardia. That certainly tells you a good bit of information. However, does it speak to the issue of stable or unstable? No, it doesn't. How about the fellow on the right? Perhaps the picture on the slide doesn't paint a picture for you, but connected to a live human being who is sweating, grimacing, and perhaps is acting confused, and now you have yourself an unstable patient. I will take the patient's presentation every single time. I might need the rhythm strip eventually in order to determine a proper course of action, but I do not need it to answer whether the patient is stable or unstable. So just how many signs and symptoms do I need to make a determination that a patient is unstable? Does one do it? It might, and I'll address that in just a minute. Generally though, it will be a collection of a few different findings that helps you to make that call. Now, if you have a patient who is experiencing altered mental status, that is somewhat of a deal breaker when it comes to being stable. The altered mental status in the setting of a suspected or confirmed dysrhythmia is likely the result of decreased perfusion to the brain, and thus a big problem. There may be a couple others that you could throw in the category, but rarely are they going to be presenting alone, things like severe congestive heart failure or chest pain. The altered mental status can present alone because the brain is so quick to react to a decrease in oxygenation. Some of the other signs and symptoms that you may encounter, likely in clusters, are difficulty breathing, chest pain, crackles, other outward signs of CHF, diaphoresis, cool and clammy skin, cyanosis, decreased blood pressure, dizziness, lightheadedness, and I'm sure there are a few others that I may be missing. So where does all of this leave us? It leaves us at the point of understanding that a cardiac rhythm is not necessary to make an initial impression that your patient may have a dysrhythmia and that they are stable or unstable. In fact, a poor clinician with a rhythm in hand many times will make the wrong call because all they see is the paper and they totally miss the patient. Don't be that person. I challenge you, please do not be that person. Do a thorough assessment, read your patient, make a call in your head, and then look at the rhythm strip. If the rhythm supports what you're seeing, then act appropriately from there. If it doesn't, then take a step back, dig some more. Could your tachycardic patient with altered mental status be hypoglycemic? The art of patient assessment is the entire key to being a competent clinician. Perfect it and preach it. Otherwise, I'll be sending you a cookbook for Christmas. For Take 5, I say thank you for listening and stay safe out there.